So this year we're meeting to talk about spine trauma, and if we look at the big picture, there are truly two unsolved diseases in mankind. One is injuries to the nerve cell. We cannot replicate these. And the second one is tumor disease. And as is the case with any unsolved disease process, there are a lot of research efforts, there's a lot of publicity put into these diseases. There's unfortunately also a lot of misconceptions and charlatanery taking place through the media and in our minds and in business also, sadly. And these are three circumstances that really adversely affect sometimes our ability to render care. Our spinal cord is just an amazingly complex structure that is so fragile, yet can tolerate such incredible trauma. In this particular meeting, we're obviously going to talk about diagnosis, emergent treatment, surgical treatment, emerging cord regeneration strategies, rehabilitation. What's going to be unique in this meeting is we're also going to preface it with a patient, a colleague of ours who got injured and who's willing to talk about his experiences from a physician perspective. We're going to talk about regeneration strategies, but we're also going to talk about, in the conclusion, with a patient, a friend of mine, who is living with spinal cord injury and is going to give us a very personal revelation of how life with spinal cord injuries is. Spinal cord injury repair is obviously a very cool theme, something that we'll see in the media immediately hyped up, and we have some very good speakers that will talk to us about that. The ultimate goal is return of function. And yet at the present time, as we'll see, we're still seeing our patients tethered to their various contraptions, and hopefully we can emerge beyond that.
Good morning. The first speaker I will ask to come forward, Dr. Ernie Franz.
Good morning. It's just an honor to be here and to be able to share the story of what happened to me. I am an emergency physician. I've been in the Seattle area for 17 years practicing and had a life change, as you will see. I'll start with one of my favorite quotes. Variable and therefore miserable condition of man. This minute, I was well, and am ill this minute. I am surprised by the sudden change and the alteration to worse. For we study health, and we deliberate upon our meats and drink and air and exercises, and we hew and we polish every stone that goes to that building. And so our health is a long and irregular work. But in a minute, the cannon batters all, overthrows all, demolishes all. A sickness, unprevented for all our diligence, unsuspected for all our curiosity, nay, undeserved, summons us, seizes us, possesses us, destroys us in an instant. So 4 years ago, I was bicycling on Bainbridge Island and was hit from behind by a very intoxicated teen driver on a Monday, 4:30 in the afternoon. I never did see him coming at all. And was airlifted to Harborview. I was conscious after being hit. So my arm fractures were repaired quite nicely. And when I was allowed to awaken, they realized I really was not moving very well. And so an MRI on day 6 revealed then a cord contusion at a level C3. Functionally, I'm at a level C5, initially categorized as an ASIA C, and then a couple months later moved to, fortunately, a better prognosis at an ASIA D. 8 weeks status post spinal cord injury with weight loss of close to 30 pounds, just basically muscle atrophy. I was beginning to stand some with assistance in abdominal binding and leg wraps. I went home at 4 months in a wheelchair, my wife becoming my caregiver at the time, and a physical therapist who was extremely creative with me and doing physical therapy every single day. So 6 months, status post-STI, I was able to do the Chili Hilly on a recumbent tandem on Bainbridge 33 miles. You'll see my walker, which I was using at the time in the left photo, which I would go from my walker then to the bike. At 11 months status post-injury, we had rigged up a treadmill with a climbing harness in the garage, and I was able to work on gait training and also began bicycling on my own. And the goal then became to bicycle to finish the ride home for me. So exactly 1 year to the day, this time with a police escort, about 20 friends, and I cycled home the 4 miles that I didn't make the year before. And this is going past the exact spot where I was struck. So I was asked to talk about the impacts of spinal cord injury, and they certainly are many and have been very much life-changing for me. There are many negative changes, and there are some positive ones too. These are things that I have listed that I deal with either every single day or nearly every day that are still significant issues for me. Just a loss, certainly, of the life that I had known. And of course, financial loss is also huge, as I've not been able to work in the ER. And then at this point, I fortunately had good disability, but that even as well will change in about a little over a year. From my injury, there was no lawsuit. There was a lawsuit, but there was nothing that came out of that, as the family was very much a broken family with no resources, and that continues to be a sad situation for them. On the positive side, you know, as I've said, it has been a life change for me, but my relationships, which I always thought as a physician would grow in time and with age, have very much been changed and altered. I always thought, you know, when I was 60 or 70 or when I retired, I could delve into my community more and deepen those relationships, and that hopefully my wife and kids would hang on with me to get through that. And I've realized that as what happened to me, life can change in a moment. And we are here to impact community and relationships with family, and the legacy that I have in my children is very, very important to me. I am a peer mentor for people with spinal cord injuries here at Harborview, and serve every month to come and lead a panel discussion where we encourage people to find life, knowing that they can find life again on the other side of injury. And so when I think about improving outcomes in spinal cord injury, you know, I think as a physician, the usual outcomes, no complications, minimal blood loss, successful surgery, excellent technique. But my perspective at this point now is certainly that, plus the relationship that each of you have with your patients. And that comes down to just a slight, sometimes even subtle changes in your behavior and your attitude and your relationship with those patients. And I see all of you very much as healers, and who through some very understanding words, very good eye contact, sitting on the side of the bed, a gentle arm on the shoulder, but just your attitude can really be an encouragement. And of course, you're seeing a lot of people right at the time of injury, which is, it's very unknown where they're going to go, especially in a case like my own where I had an incomplete injury. It's hard to know where they're going to go. But you, in a sense, have an opportunity to be a coach for them, an encourager, and to help them begin to find life. It will be a new life. It will definitely be a different life. It's not going to be the life that they had before, but it can be new, and it can be very fulfilling and satisfying. And a week ago today, this very day, I was able to bicycle 100 miles with the Mike Utley Foundation in support of spinal cord injury research. So I have been training hard and working hard on my recovery, and I still find a tremendous amount of life and satisfaction by being back on the bike. It's about overcoming my injuries and moving on. And so in closing, I think very much you have the power to plant seeds of thought that can really create or enable the dreams of others. Even early on, there are words that physicians spoke to me in the first few days that I still very clearly remember and still encourage me to this day. This is a quote, the second thing, from John Wooden, UCLA coach: don't let what you cannot do interfere with what you can do. And lastly, I want to encourage you to just give yourself to the relationships around you, your family particularly, and also your community, your friends, because those are the people really that matter in this life. Beyond what we do here, which is very, very important, just our relationships are vital. I thank you very much. It's an honor to be here for you.
We'll start with Mike Fehlings again. What prevents spinal cord injury recovery?
So let's start off with a case, and I think it's always very useful to think about this as a case. And this is a terrible case that I managed last summer. This is a friend of one of our neuroradiologists, and they were vacationing in northern Canada. This young man went out for a morning swim and became a C4 tetraplegic after a dive into shallow water. And here is his CT, and here's the MRI, and flexion distraction type of an injury, severe cord compression. And if we look at the area here of the cord, there's an area on MRI here which is suggestive that the outcome here will not be good, hemorrhagic necrosis. However, there's an area of ongoing secondary injury which actually extends above the injury right up to the C2 level and goes down to about the C7 level. And so this is the zone of secondary injury, which always occurs. And so when I hear, well, he's a complete injury, there's nothing to lose, this guy's got a lot to lose. He could end up a ventilator-dependent tetraplegic, he could die, you could potentially get at least a level back, and you don't know here, right? And so there are many issues here to consider. So let's try to frame this perhaps in the context of some key questions. Perhaps your patients might ask you, what's the emerging research? Perhaps there might be some research studies that are ongoing, and certainly Harborview is an active center for SCI research. Well, what can be done in the acute period in terms of decompression? We've heard a bit about decompression, so I'm going to talk to you a little bit about the emerging evidence from the Staskus trial. This was presented earlier this year at the AANS a meeting, and these data are emerging in an interesting way. Will any neuroprotective drug other than methylprednisolone be translated? And of course, methylprednisolone is controversial. And the answer is yes. I'm quite optimistic that in the next 5 to 10 years we are going to see one of a number of drugs emerging. Sethrin is a recombinant protein that blocks a molecule called Rho. This is a key inhibitory molecule that prevents nerve cell regeneration. And this is now in phase 2 clinical trials. There are a number of other molecules which are out there. I've alluded to a couple of them. Can bioengineering or gene therapy deliver? And the answer is it probably will, although this is further along. I'll share with you some late-stage preclinical work using a novel type of gene therapy using what are called zinc finger protein transcriptional factors. And these are molecules that actually bind to sequences of the DNA to upregulate in a very safe and efficient way all of the transcripts related to that gene. In addition, I'll talk briefly about bioengineered scaffolds. And this is of direct surgical import because surgeons will be the ones delivering these bioengineered solutions. And what about cell-based therapies? Yet another local delivery strategy that will also be delivered by surgeons. And it's very likely in the next 18 months we will be seeing a neural stem cell trial in North America. And I'll talk to you a little bit about the rationale behind that. And what about the barriers posed by the chronic injury? And this will remain a challenge until we can solve the glial scar. And there are some bioengineered solutions that are being looked at right now to inhibit glial scar formation. I'll briefly allude to this. So if you remember the key points on this slide, in essence, these are the pearls, and you think about this in the context of the patient, perhaps you might be able to walk away with a few emerging concepts. This is a fellow with a diving-related spinal cord injury at C6-7, and he was labeled as a severed cord. This is in the early 90s, and that's totally wrong. The MRI shows that the cord is not transected. In fact, it rarely is. Even when the radiologist calls a cord transection, it usually is not. This is a post-mortem image from Rauschning's slide collection, fortunately not from the same individual, but I show this to highlight the concept of the primary injury, which is the initial impact, which is really the key determinant in terms of how someone does. And then everything we're treating from then is trying to mitigate against the secondary injury. So instability is a type of a secondary injury. Compression is a type of a secondary injury. And the complementary factors of the primary and the secondary injury sets in motion a series of events that culminates in progressive cell death. And there was a lot of work in the late 80s and early 90s around what was then called the vascular hypothesis of spinal cord injury. It was very controversial at the time, but the evidence has now supported this. And this is where there's disruption of the blood supply in the center of the cord, and the surrounding area of the cord becomes ischemic. And of course, this underlies our protocols to try to maintain the blood pressure at the time of the injury. And then if we look in the zone, in this penumbra zone, and if you stain nerve fibers in a special way, and here they look green, they're stained on a confocal microscope, you see progressive calcium-dependent nerve cell degeneration. And then on the bottom right, this is a panel from a human neuropathology a section. What this is showing is the cavity corresponds to the area of the initial hemorrhagic necrosis. This is the glial scar with astrocytes. That corresponds to the area of ischemic deposition. And the glial scar is beneficial in that it limits the secondary damage, but it's harmful in that it prevents nerve cell degeneration. So it's very much a two-edged sword. And then you have an anterograde and a retrograde retraction, if you will, of the nerve fiber. So just remember this cascade of events. And I think what you'll see then will be the rationale for potentially considering decompressive and reconstructive surgery, the rationale for pharmacological neuroprotective approaches, the rationale for potentially reconstructing the vasculature, and then ultimately in the chronic situation trying to replace lost cells or even using bioengineered scaffolds to try to reconstruct the injury site. And so we're going from the most doable to the most challenging, and clearly our best option for minimizing the long-term disability that an individual may experience is to give them the optimal care at the time of the original injury. So this is just a slide which just summarizes a lot of what I've just said. The secondary injury events that I've described have been well worked out. The time course, though, will vary from seconds to minutes to hours to even to weeks. And so even when patients are on our ward, there can potentially still be programmed cell death which is occurring. So you need to watch the patients quite carefully. This is set in motion by ischemia. You get the cellular events, ionic shifts, glutamate release, and then wave of secondary degeneration. It's a cartoon of a nerve cell. And we can think about the regeneration obstacles. So we have cell death, the glial scar. We have various myelin inhibitory molecules. We have the limited ability of the growth cone to regenerate. And what's cool is that each one of these barriers potentially is solvable. And in fact, each one of these targets is now in early phase clinical trials. So really quite a remarkable advance when we think about the translation of biomedicine into the clinic. Can we intervene in the acute setting to try to mitigate against a secondary injury? And this has been quite a challenge to undertake. We actually tried to do a randomized trial in this circumstance, and the challenge here is that there really isn't equipoise. And if you don't have equipoise, it becomes very difficult to randomize patients. So I don't think there are a lot of patients and families who have this kind of an injury who are going to want to be randomized to early versus late. And this becomes the challenge. And so after trying to do this, we decided to do a prospective non-randomized study, which is class 2 evidence admittedly, but at least I think we're going to be able to get some answers out of this. And in fact, this model I think is working. So this is a multi-center study, my main collaborator being Alex Vaccaro in Philadelphia. This is the breakdown of the patients by Asia impairment scale, and there have now been almost 300 patients enrolled. I'll present the data on 205 patients, and we have a year follow-up on these patients now. And about 40% have an Asia A injury, and around 60% have varying degrees of incomplete injuries. And we'd hypothesized that the median time to decompression would be at 24 hours. This has been operationally defined by the Spine Trauma Study Group to represent the early cutoff. And it's really a trade-off between biology and logistics, if you will. There's nothing necessarily magical about this. This is kind of like the 6-month cutoff in the myelopathy group, if you'll think about that analogy. In terms of looking at the covariates, you have to be very careful when you design this kind of a study. Are the injury severity scores similar? Are the comorbidities similar? The age, the gender? Are the baseline impairment scales similar? And the bottom line is that they're all similar. This shows the distribution of the age impairment scales, the ISS and the Charlson comorbidity indices are similar. So here's the bottom line here. The bottom line is that we're not seeing the home run effect with surgery. And that's not really a surprise. I don't think any of us really are going to think that we can cure spinal cord injury with an early intervention. However, the results are interesting. So what we've graphed out here on the y-axis is the percentage of recovery. And on the bottom are patients who either don't improve on the age impairment scale, patients who have a 1-grade improvement, or patients who have a 2 or more grade improvement. And the bottom line is that when you analyze this with multivariate approaches, that it's highly significant for patients showing a 2 or more grade improvement in change. And what this translates to is that about 1 in 5 people is potentially walking away from an injury where they might not be able to get a significant degree of recovery. And so the initial conclusions from this, and I've really kind of breezed through this, is that certainly early decompression is safe. Now these are patients with an isolated cervical injury. We're not talking about patients with significant comorbidities or with polytrauma. And that there are logistical hurdles which prevent all patients from undergoing this. And this is interesting from a public health perspective. And that the initial results suggest that the rates of neurological recovery are interesting and that early decompression may be beneficial in this patient population. We've now analyzed the 1-year results, and we have complications data as well, which show that we're actually reducing the rates of nosocomial pneumonia by around 20% with this kind of an intervention. Now, in terms of pharmacotherapy, there have been 2 compounds that have been studied fairly intensively, the corticosteroids and GM1 ganglioside, and the level of evidence for either of these compounds is fairly weak. Methylprednisolone is used, although perhaps less so. The bottom line, though, from the trials, if you look at it in a bit of a different way, is that they do show some kind of an effect, and so there's a potential for neuroprotective strategies to actually work. There's a big difference between something working a little bit or not at all. And it's also very clear that we need better agents, and basic research has identified a number of potential strategies. So just briefly about riluzole. Riluzole is a sodium glutamate antagonist, and sodium is key to cell injury. So, and you'll remember this from your biology, that when you injure a cell, you lose the gradients of sodium and calcium. Sodium goes into the cell swells, and it turns out that this is the main way that calcium gets into the cell, through reverse operation of the sodium-calcium exchanger. If you apply riluzole to animals, you get markedly improved rates of recovery. And this is what's shown here in the black line. These are animal studies where animals have received the drug, and these are quite large improvements in functional assessment. And here, these graphs show the amount of tissue protection at the injury site, and at the bottom are actual images. So here's a control image with a large cyst, and here is a representative section in an animal treated with this compound. And then there are very large degrees of protection at the injury site and adjacent to the injury site. So this all looks great. So why hasn't this been translated? And the reason is it's off patent, and that these are extremely expensive studies to undertake. In fact, riluzole is dirt cheap. It's $10 a day. So it's very difficult to try and take, for a pharma to try and take a compound like this forward. However, it's in the public interest to do so, and what's changed now is the evolution of clinical trials networks. So this is a trial that will be actually starting later on this fall. FDA-approved compound, very strong preclinical data to support this, very good safety data. So just an example that there is hope that in fact we will be seeing improved compounds, and there really is very strong evidence to support this. Now, a little further upstream, if you will, is this issue of the vasculature. Ultimately, if you think about trying to reconstruct the tissue, you need to reconstruct the vasculature. And so here is potentially where gene therapy may actually play a role. Now, the problem with most types of gene therapy is that you deliver one single type of splice variant of that gene. The problem with vascular endothelial growth factor, or VEGF, is that there are multiple splice variants, and you need to have expression of all the different splice variants of that gene to get efficient formation of the blood vessels. So this is where zinc finger protein transcriptional factors come into play. And these are molecules that bind to regions of the DNA, and they actually trick the DNA to then expressing the molecule of choice, and you get all the transcripts expressed. And so in fact this has been designed, and these are experiments that we're doing in conjunction with a biotech company in California. So these are just images where we've labeled the constructs with a green marker, and so we're getting very efficient transfection. This is perhaps a little more subtle, but this is showing the angiogenic effect of the VEGF. So if you look at the bottom panels, these are control sections, and here we've stained for the blood vessels. And so there are some blood vessels, but not a lot. And then if you look in the top sections, you get the impression that there's probably about 50% more blood vessels. And when you do the quantification, it turns out, in fact, that that works out. Remarkably, though, we also see a reduction in cell death. And this is interesting because it turns out that VEGF is actually an important growth factor for nerve cells in oligodendrocytes in the brain and in the spinal cord. And significantly, there are a very strong behavioral effects. And what we've now shown, in fact, we'll be presenting this at NASS in a couple of weeks in Toronto, is that there are very long post-injury time windows that are at least 24 hours. And so this is potentially something that is being looked at very seriously in the context of a phase 1 trial. And this construct is actually being used currently in phase 1 trials in diabetic patients with diabetic vascular changes in the legs. Now, what about cell replacement therapy? So I've got this little movie here to kind of give you the concept. So here we have the normal spinal cord. We have myelinated axons. These conduct signals in a saltatory fashion. We have sodium channels that fire at the nodes of Ranvier, the myelin sheath that provides an insulating layer, and then right under the myelin sheath we have molecules such as Caspar and potassium channels that are very integral in terms of this action potential conduction. In the setting of spinal cord injury, most patients have what's called a discomplete injury. Even when there's a severe injury, there's a rim of tissue which is partially intact. But if you look at the rim of white matter closely, the axons are demyelinated because you lose the oligodendrocytes. As a result of this, you lose the myelin sheath, so that interferes with electrical conduction. And at the molecular level, you lose the normal nodes of Ranvier. And so you lose this saltatory conduction and you get conduction block, which occurs. So when you think about it now, you have a single cell that's lost, and potentially you can use the underlying scaffolding of the patient's own spinal cord, replace a single cell type, which can differentiate into oligodendrocytes, remyelinate the axons, and reconstitute the nodes of Ranvier. And it sounds like Star Wars, doesn't it? except it actually works. And the evidence now is, in fact, being reviewed at the level of FDA, at Health Canada, very seriously in terms of taking phenotypically adult neural stem cells in cell lines and actually using these as a transplant construct in patients. This is a little bit of evidence from our own lab, and this has been validated in other groups around the world. Again, the cells are labeled in green. They integrate beautifully with the underlying spinal cord, and you get very efficient remyelination. So YFP is the yellow fluorescent protein. MBP is the myelin-basic protein, and that's the overlay. So they very efficiently make myelin, and then they wrap themselves beautifully around the axons, and you see significant degrees of recovery. Now, these are in animals that are much longer term after the injury. So these animals aren't getting transplants for several weeks after the injury. So the degrees of recovery are smaller, but nonetheless they're still important degrees of recovery. And you know, relatively small degrees of improvement in somebody with a significant spinal cord injury can still potentially have an important impact. There are techniques that are being developed by our group and others to try to visualize this on MRI, and these are T2 weighted spectra, and these are pseudocolored images taking the T2 weighted spectra, and you can dissect out the myelin component. The demyelinated segment looks yellow on this pseudocolored image, the blue representing the myelin signal. And this is important because you now have an objective readout in the context of clinical trials to actually assess remyelination. So this is being looked at right now very closely by the regulatory authorities, and I'm hopeful that we will see a trial. And again, recall, these are adult neural stem cells, so all of the issues, safety issues, ethical issues, etc., regarding embryonic stem cells completely don't wash here. So the FDA is actually looking quite favorably at this kind of technology. The chronic injury is a different story, though, and you hear stories about patients going overseas and they're getting various types of stem cell transplants. The problem is, if you just put stem cells in a chronically injured spinal cord, it does zero. And the reason is you have the cyst, you have the scar, and this is just a stain to show the scar. This is a chondroitin sulfate proteoglycan stain. And if you look for stem cells, and the green cells are the stem cells, and they're wrapped around by the scar tissue, and they don't migrate. They don't differentiate, they don't integrate. Emerging evidence, though, indicates, using various bioengineered strategies, that you can actually significantly knock down the extent of scar formation. This is using an XT1 DNA enzyme. The top shows a control section with scar, and the bottom is treated with this kind of an approach. And this, in fact, can promote the growth of neural stem cells in a chronically injured spinal cord. Now, that's still up the preclinical realm, but nonetheless is hopeful. And ultimately, for patients such as the one that I presented earlier on, we probably down the road would need to look at some kind of a reconstructive technology with some type of a bioengineered scaffold. But that's, again, significantly upstream. So I'm just going to close very quickly with a clinical trial using a recombinant protein. So this is now Star Wars, which has actually come home, which is applied by surgeons. And in fact, our colleagues here in Seattle were a key contributor to this study. So this is using a protein that knocks down Rho. And Rho is a key inhibitory molecule. This is the nerve cell membrane. And there are various inhibitory molecules that are expressed in the myelin, central myelin, not peripheral myelin. These get activated, and then you get activation downstream of Rho. And this causes cell death, and it also prevents the nerve cells from growing. So this is kind of a key discovery that's been made in the last 15 years. And proteins have been now developed to knock this down. And the one that we studied is called sethrin. And this is actually delivered using a fibrin sealant extradurally. It's probably easiest to show this in the context of the movie. And you can see the importance of having access to the cord and decompressing the cord. So now we have access, we've decompressed the cord, and this is actually mixed with Tisseel, and it's applied extradurally. So you don't have to open the dura, you don't have to do an interspinal injection. The C3 Rho inhibitor, which is the real name for sethrin, has been modified to allow very efficient cellular penetration. About 98% of it gets into the spinal cord. So we did a safety study. Again, there's not a control arm here, so I can't really tell you if it works, although the data do look promising. It's a dose escalation study in patients with a complete spinal cord injury. 37 patients enrolled in the study, and the data are currently being written up. This has now been presented a number of times at international meetings. So the bottom line here is that it's safe. There are many, many adverse events that occur in the SCI population, but none specifically related to Setharin. And the rates of systemic exposure are extremely low. Less than 1% of this gets into the systemic circulation. And these are the motor scores here. I'm just going to show some of the scores for the cervical spinal cord injury population, just to show that there is some degree of recovery that occurs spontaneously with placebo groups. And there's an interesting U-shaped curve suggestive of an optimal effect with 3 milligrams of Setharin. And we're seeing around 2 to 2.5 times the rate of neurological recovery. Again, I can't say whether or not this is just one of those things, but it's enough given the safety data to warrant going to a randomized trial. So that's in fact what is going to be happening later on this year. So the neurological results look interesting, but again, you know, we can't recommend this to our patients yet. This is an investigational compound. So just kind of in closing, what else is going on out there? Well, we've seen a trial with activated inflammatory cells, the ProCord study, and unfortunately this was discontinued as a result of safety issues. There have been a variety of cell-based transplants around the world, small studies which haven't really shown positive effects. The minocycline trial going on in Canada, the Rho inhibitor study, the no-go antibody study in Europe and in Canada. Hopefully neural stem cell transplants will move forward. The riluzole trial, which I've just described, hypothermia, which is, there was a lot of hoopla, but there's now a study going on in Miami, and we may see a Schwann cell study as well out of Miami. So a lot of activity from a translational perspective, and this is just to acknowledge and thank the team in Toronto. Thank you very much.
So we will now hear a little bit more on that. Brian will give us a lecture on transitional spinal cord injury research. How applicable is it?
Okay, good afternoon. So what exactly is translational research? You know, it's interesting that it is probably a nebulous enough of a concept that people have actually done academic kind of work to define it. It, in this case, is being defined as the application of basic scientific discoveries into clinically germane findings and simultaneously the generation of scientific questions based on clinical observations. Now, there's now a journal of translational medicine, and this is from the inaugural issue of this open access journal. And it's defined here as a two-way road, and I think this is a very important statement. This should be regarded as a two-way road, bench to bedside and bedside to bench. However, bedside to bench efforts have regrettably been relegated to a Cinderella role because the scientific aspects are poorly understood by full-time clinicians, and the difficulty of dealing with humans is poorly understood and appreciated by basic scientists. You know, as to the question, how applicable is translational research? Well, it should be pretty obvious. And in fact, you know, Michael really described a wide range of translational research initiatives. But it really is, it's a good question. And it's a good question because I think it's hard for both scientists and clinicians to really grasp the size of this space that traverses the bench and the bedside. So we're going to talk a bit about that. So here we have our scientist, and he's looking at his therapy and he's thinking, wow, this looks very interesting. This looks very interesting. The problem is that there's a lot of things that look very interesting. This is an abbreviated list of those that have been published in this year alone. And when you look at a list like that, you think, gosh, you know, that's a rather overwhelming sort of thing. And in fact, if anybody, the patients are rather annoyed by the fact that there are so many of these types of studies out there. One of the things that I was very interested in is actually EPO. So here's a compound that has gone through this process. So this looks very interesting, and people have been talking about doing a clinical trial. And in fact, the science, the preclinical work on EPO has been extensive. This has been shown to reduce secondary damage and improve functional recovery in animal models of spinal cord injury. And here are a number of studies. Now, because people were kind of talking about, a clinical trial in this regard, I thought, it would be very interesting to, at least before embarking on something like that, to compare EPO with darbepoetin, which is a version of EPO that is a more bioavailable compound. And in fact, clinically, while you give EPO on a daily basis, you give darbepoetin on a once every 2-week basis. And it's actually in small studies, preclinical studies, being shown to have some neuroprotective effects. So we embarked upon this in my lab, and I'm just going to blast through the results here. We basically did a thoracic contusion injury, divided up randomized the animals to EPO, Aranesp, or saline controls, followed them out for 6 weeks, and then looked at their spinal cords to see if there was any neuroprotection. And certainly after this host of literature that had demonstrated this positive effect, we thought that it would be interesting to see if darbepoetin would be any better. And what we found is that none of them worked. None of them worked at all. There was no functional recovery, and there was no improvement in white matter sparing. And we published that this year. In fact, about 3 months before Dalton Dietrich at the University of Miami published almost the exact same reproduction of this EPO data, and also found that it didn't work. Now, the reason I bring this up is not, this is, I think, hopefully going to be a growing trend, but I want to show you a little bit about the review process. So this was reviewed by a scientific journal, and these were the comments that I got in the review. This reviewer has knowledge of at least 2 other such EPO preclinical trials using contusion SCI that also showed no significant effect, and hence have not been reported. Since these types of studies require substantial effort and resources, it's important to have this information available in the literature. Now, the second thing that was said in this review that I received was that mixed results on an agent could mean a variety of things, including that the experimental variables are responsible. Methylprednisolone, for example, showed the best results in preclinical testing in the rat on mild injuries, suggesting that severity of injury was an important factor. Anesthesia protocols, rat strain, sex, dosing, time to begin dosing, duration of dosing, etc. are all potential variables to consider. And I thought this was very interesting to see. For one, it tells us that there is a publication bias in science that I think hinders us. And there's also this, which I think it represents a bit of a translational disconnect. So it's felt that these kinds of experimental variables are important for the efficacy of these therapies in these experimental models. Things like severity of injury, anesthesia protocols, what the strain of the rat is, what the sex of the rat is, what kind of dosing regimen is given to the rat in terms of time, dose, duration of dose. And when you think about that, it brings me back to my weekend at call in April. So there it was a beautiful day just like this, and about 4 o'clock in the afternoon, this 19-year-old woman rolled in from Whistler, student, healthy, 40 meters down a cliff, associated femoral shaft fracture. And about 3 hours later, this gentleman rolled in, having fallen through the roof of his house, 52-year-old male, 10 feet through a ceiling, no other injuries. And then a couple hours after that, this 30-year-old IV drug abuser being chased by the police rolled in, still under the influence of a number of drugs. Intubated, sedated, multiple trauma, scapular fracture, pelvic fracture. And shockingly, as we were assessing him, this woman rolled in. 42-year-old woman, rollover MVA, diabetic cripple, chronic renal failure, and even with microvascular dementia. So when I look at this, and I looked at this review, and you think, okay, so if these are the things that are really responsible for the efficacy of these therapies in experimental models, then how in the world are they going to be effective in the diverse reality of human spinal cord injury? And I think indeed this has most certainly contributed to our past failure to demonstrate efficacy in pharmacological trials of acute spinal cord injury. And I think methylprednisolone and Cygen were very good examples of this, where you clump a number of patients with all different varying injuries, severities, and other conditions, and then try to apply a therapy to that. So this is a bit of a translational disconnect, and unfortunately, in this regard, in our frustration, we are not alone. This is a review article on 1,026 experimental treatments in acute stroke. And the point of this article was to point out that a common perception of neuroprotection research is that everything works in animals, but nothing works in people. And in fact, they point out that despite the 1,000 treatments that had looked promising in stroke, the number that had actually gone to clinical trial was around 30, and the number of those that had actually shown any benefit was 1. So the question then arises, well, how do you then increase your chances of succeeding if you're doing preclinical work and trying to translate things into human trials? And in fact, the stroke community has tried to formalize this by coming up with recommendations on what things should we see in our animal models before we take something to clinical trial. Things like adequate dose, time window studies, etc. And this is interesting because when you look at the types of questions that they ask, refining the formulation, deciding what you're going to give, defining the dose, the delivery mode, the efficacy time window, because in experimental animals you can give the therapy at the time of injury, but of course that's obviously not clinically relevant. So finding out how long of a window you have to give the therapy, confirming that it actually has an anatomic effect, and demonstrating robustness. In a sense, we've all witnessed this type of process. We saw it in the translation of BMP into clinical trials, right? When you consider all those studies that Scott Bowden had done to try to refine the formulation, refine the dose, not so much the time window, but defining that it had an anatomic bone-forming effect. And that process took a hell of a long time. And in fact, the problem with this is that it is an insanely time-consuming and expensive process to do. And as you know, for something like what Michael pointed out for riluzole, where there is no big pharma support for a massive preclinical program, I mean, it would be an insanely expensive thing to do, and it's kind of fallen onto the scientific community to do this. So, are there examples of this? Well, sure. The first NASCA study used a dose of methylprednisolone that was later shown in animal studies to probably not be sufficient. So the dose was significantly increased. Now, whether that made a huge difference in the process, but the fact is 450 patients underwent this trial with a dose that was not supported by the preclinical data. And here's another one. So here's the one study that was published before autologous macrophage transplantation was commercialized in Proneuron Biotechnologies and moved forward. One study. So that's one of the things I think that challenges us in the translational scheme from the preclinical side. On the other end of the spectrum, at the clinical side, and I hear this from colleagues when we speak about this as well, they say, well, you know, it looks safe, it looks pretty good, and so let's just test it. Let's test it in humans. And of course, the challenge with that is again, the fact that this human validation is insanely hard to do. So here is, I think, how everybody would expect the flow of validation to occur. So you have a molecule or some sort of preclinical development phase, and at some point in time it gets put into the initial phase 1 study, and it goes through its human validation to become a drug. Now for SciGen, or GM1 ganglioside, this process alone of human validation took 14 years. Okay, the phase 1 study began in 1986. This was published in 2001. So this is a huge, very long process. And so to just say, well, you know, it looks promising. Let's just take it to clinical trial. There is a huge challenge in doing that, in translating that. And so why is it taking us so long? Well, this is one of them. This is the issue of spontaneous recovery. So if you even take the most heterogeneous or homogeneous population of patients you can, cervical ASIA A patients, this is the data from the SciGen trial to describe what their spontaneous neurological recovery was over time. So this delta represents the number of patients that started as ASIA A's and then ended as ASIA A's at the 52-week mark. So that ASIA represents the spontaneous neurological rate. Now with that data, you can do a power analysis for how many cervical patients with ASIA A injuries you would need to complete a clinical trial. And the number for that, if you were to look for a 5-point improvement in ASIA motor score, would be about 480. So 240 patients per group, if you were to randomize, do a single randomization. Now, when you look at the SciGen trial, The SciGen trial recruited 332 cervical ASIA 8 patients, and it took 28 neurotrauma centers 5 years to do this. Okay. So the challenges of trying to do this type of translation are huge. And incidentally, for cervical ASIA B patients, the number is closer to 2,200. So this is why, when you look at it and you think, well, why is it that we haven't been able to say, see a big difference in some of the small early studies of early versus late surgical decompression? Well, when you have this type of variability and you include ASIA A, B, and C patients, it's quite obvious to see why you might not see a difference in a series of, say, 32 patients, right? I mean, we're talking about the need for large numbers, and it's for this reason that I think the real strength that Michael has taken Staskus forward as a large multi-center trial to look for these kinds of differences is a way in which the translational research sphere is attacking some of the challenges that we now know or have now learned from our past experiences in clinical trials. Recognizing that this huge variability exists, it becomes clear why, number one, it is difficult to interpret the nature of recovery in media reports, such as the Kevin Everett situation. It is difficult, albeit less difficult, to interpret the nature of recovery in non-randomized clinical trials. And it also becomes clear why we need so many patients to actually finish these types of trials. This is a document that was published at the end of 2006 as a sort of a post hoc analysis of the SciGen trial and other clinical trials to try to get a grasp on this issue of what is the spontaneous neurological recovery after this injury, and how does that influence the way in which we would design a subsequent trial. So in closing, how applicable is it? I think that, and Michael's lecture speaks to the fact that, undeniably progress is being made, albeit slowly, and certainly for our patients, too slowly. Our past experiences and our increasing awareness of some of these challenges will only help to increase our chance of success. And already, the way that a riluzole trial will be designed is going to be much different than the way that, say, the NASCUS trial was designed 15 years ago. Okay, so as we move forward, I think the chances of success will increase as we recognize some of those challenges. And finally, this will ultimately come down to the collaboration between the scientists and the clinicians, this will be an increasingly necessary thing for us to overcome some of these obstacles. Thank you very much.
Any questions in the audience for any of our speakers?
Could you foresee yourself being willing to participate in some study which may have actually hindered your further recovery? And part B then, will be to the two researchers, how when we have these completely unpredictable scenarios, can we somehow try to instill science into this whole perspective without having 2,200 plus patients, as what Brian in his excellent lecture said?
I personally would have a tough time with that. I think that it's a balance of risk and benefit, and I think that I would take a fairly conservative approach to an offer like that. I don't know if I'm speaking for my family, but personally, I think I'd have a tough time with that.
As his wife, those first 24 hours, as a family and the patient, I think you're in shock. And I would agree with him. You want the very best. That's why I called for Jens.
It's a good question, particularly amongst the timing, because there were times in the hospital, for me, it was 8 weeks before I had really any right arm motion at all, and 11 before I got anything going in my left. And there were times that, if I had heard that, at least the placebo track was, okay and not likely to be harmful, I think I might have been interested in that. But if there was some chance to, say, set things back 10, 15, 20%, I probably would have said no, even early on, if that makes sense. And then later, where I am now, I would say, again, I would want to know, even if I'm assigned to the placebo track or the control track, that that it's not likely to be harmful, that some valuable information could be gained. That's okay, but I would not be interested in really participating in something that really may end up harming me or damaging my condition, even if it's, you know, for the benefit of others. I would not be willing to give that up.
These are important perspectives from two people with who've had severe injuries and who've shown a remarkable degree of recovery. And of course, you're also looking at it from the perspective of somebody who's shown recovery, which is a different perspective. And certainly, I think we have to balance many issues. So we have to balance whether someone is in the acute phase of an injury versus the chronic phase. How much recovery will they likely show, and have they shown? And then how safe is the treatment? Are we dealing with an off-label use of an FDA-approved compound with proven track record, or are we talking about an engineered stem cell that requires a fairly high degree of invasion? So I've participated in a number of clinical trials. I guess I'm showing my age, but I'm one of the few people around that is actually an investigator in the last methylprednisolone trial. I was in Cygen and led Sethrin. Our rate of consent in the trials is 100%. So I've never had a patient with an acute spinal cord injury turn us down. And the reason is just what it's been articulated. People are devastated. You're trying to get the best care. One minute you're whole, the next minute you have an injury you never thought you'd have. It has a devastating effect. You're scared, and you're relying on your physicians to try to guide you. And so, it puts a lot of onus on us as well in terms of trying to evaluate this. And so I think, you know, there are many issues that need to be raised. The other issue, though, I think that kind of indirectly gets to Jens's question as well, is that, in my view, the rate of spinal cord injury is severely underestimated. And the reason is that, you know, I presented a lecture earlier on cervical myelopathy. That's a spinal cord injury. You know, patients don't care if they're paralyzed because of a degenerative disc or cancer or trauma. They have problems. And people with cervical myelopathy, although I was presenting the upside to the story, there are very high rates of neuropathic pain, and these people are the walking wounded. And we have two gentlemen here, the walking wounded, and they may not appear to have a spinal cord injury, but they have a spinal cord injury, and our perceptions are different, and also the way the treatment approaches are being oriented are different as well. And as researchers, we're starting to learn this, that we better pay attention to neuropathic pain. We have to pay attention to some of these other issues that can impact on people's quality of life.